بسم الله والصلاة والسلام على رسول الله. السلام عليكم ورحمة الله وبركاته. بداية موفق للجميع. الحين بنبدأ مع محاضرات البيدياتريكس. محاضرة اليوم هي Proteinuria in Hematuria. محاضرة شوي طويلة. الدكتور يقول نضاف معلومات إضافية عشان تكون مرجع لنا، بس يعني I don't know how much I trust that, so take it with a grain of salt. طيب هذه الأوبجكتيفز اللي لازم نغطيها. First من اسم المحاضرة عندنا Proteinuria Hematuria. إيش بنغطي بالضبط؟ We need to know the glomerulus' normal histology, how to measure urinary protein, types and causes of proteinuria, عندنا transient والpersistent, nephrotic syndrome، كل شيء تقريبا عنه. هنا خلصنا proteinuria. Hematuria, definition, etiology, assessment, وال 3 types. طيب, let's imagine this is your patient, coming with her mother, of course. She is symptomatic. She's complaining of puffiness around her eyes. So we have periorbital edema, weight gain. She slouches and looks sick and complains that her socks feel tight and uncomfortable despite being her size a while ago. هذا يعني very extreme case عشان يكون شوي obvious، بس كثير بعد من الأطفال يجون asymptomatic وراح نغطيه بعد في هذه المحاضرة. طيب well يعني أنتوا what did you suspect من هذا؟ You suspect هذا edema. So edema, we have different causes. In this case we're going to talk about proteinuria as a cause of edema. So let's go over the glomerulus' normal histology. The glomerulus is a tuft of capillaries. We have the afferent arteriole and the efferent arteriole. They form this tuft. We have here's the Bowman's capsule. Here are capillaries, and we also have the wait, hold on. Yeah. Okay, هذه الصورة واضح. We have the endothelial cells. Here is the fenestrations. Wait, where is it? The fenestrations of the endothelial cells. تشوفون كيف مفرغة. We have also the وين الثاني هنا glomerular basement membrane عندها 3 layers حقها. We have the epithelial cells اللي يطلع منها foot processes, which are the podocytes. On electron microscopy, here is our glomerular basement membrane, our 3 layers, and our endothelium. These are the fenestrations, and here are the epidermal cells and their foot process. طيب, let's delete this شوية. Okay. هذا قلت عن السيلز. هنا عندنا شيء اسمه الانترستيشم, which has the mesangial cells. Okay. So البلاد بيطلع من الكابيلاريز هذه من الجلوميرولس وبيصير عندنا urine. The measurement of urinary protein. Proteinuria is commonly detected by the urine dipstick, usually on a random urine sample, or if you want to be more precise, you can use the 24-hour urine sample. طيب إيش يسوي؟ It detects primarily albuminuria. معناته إنه it is less sensitive to any other form of protein. زي إيش؟ Low molecular weight proteins, Bence-Jones proteins, gamma globulins, any other type of protein. فهذا ممكن downside للurine dipstick. طيب, the depth of color of the dipstick increases with increasing urinary protein excretion. Which, hello, we have negative, we have trace, +1, +2, +3, and +4. So in this urine dipstick, what do you see? We have +1 protein. طيب, هل مهم نعرف +1, +2, +3, +4 إيش هما؟ Yes, it is. طيب, concentration of protein in the urine will be interpreted as following. So أول شيء عشان أتذكره الله يكرمكم boil has 3 letters. You'll see the number 3 is significant in this lecture. برجع على هذا المثال 3 كثير. طيب عندنا نيجاتيف ما في. 3 هو البيس حقنا. فلما نقول +1 على طول فكروا 3 أول خانة. طيب وإذا قلنا trace يعني أقل من الواحد يعني شوية منه فناخذ نص. فنصه هنا نص 30 15. ف we are perfectionists, we medical students نبغى يصير كامل. ف 30 إلى 100 هذا +1 +2 نكمل من 100 بعدين نرجع حقنا صديقنا رقم 3 300 +3 300 to 1000 and +4 is more than 1000. طيب normal protein excretion in children is less than 100 milligrams per meter square per day. هذا بيفيدنا بعدين للنفروتيك syndrome actually. بشيله شوية. طيب قلنا إنه هو not very sensitive lipstick. فإيش drawbacks اللي عندنا؟ ممكن يطلع لنا false positives. False positives تطلع لنا in case of gross hematuria and alkaline environment. False positive in patient with gross hematuria, alkaline urine, samples with contaminated by antiseptic agents because they are alkaline, and after use of radiocontrast agents which are alkaline نحتاج ننتظر إنه it gets excreted out of the body. طيب كم ننتظر؟ ننتظر at least 24 hours. بعدها we test for the protein. وبعد highly concentrated urine also يعطينا false positive. طيب متى يجينا false negative؟ تخيلوا العكس يعني إيش؟ diluted urine وزي ما ذكرنا في البداية if the predominant urinary protein is not albumin. زي إيش؟ low molecular weight or other types of proteins. طيب خلصنا كيف نستخدم الدبستيك. Let's go to the types of proteinuria. So this is the first question you're going to ask إذا you found protein in the urine or if مثلا our patient اللي قلناها في البداية was complaining of edema ونبغى ناخذ ال full history حق ال urinary system. طبعا في Socrates we're going to ask about the timing and progression of the chief complaint. منها بنعرف is it transient proteinuria or fixed proteinuria. Transient proteinuria هذا يقدر يجي لأي أحد لأنه يجي from physiological stressors. So up to 10% of school-aged children and adolescents will test positive for protein in urine dipstick screening test. But less than 1% of them will have persistent proteinuria. يعني أغلبهم 9% بيكونون transient. كيف يجي transient? Common causes. So fever after exercise, dehydration, cold exposure, stress. Sometimes عندنا non-renal cause of edema. So congestive heart failure, وبعد in cases of seizures. In the transient, proteinuria يكون low grade, so it usually does not exceed +2 on dipstick. The mechanism of transient proteinuria is unknown, and no evaluation is needed for these children. All you have to do is reassurance. What about fixed proteinuria? عندنا 3 types. We have orthostatic, postural, glomerular, and tubular. كيف نفرق بينهم؟ قبل ما نفصل فيهم أول شيء يعني عشان ناخذ الurine sample صح أنا قلت إنه ناخذ random urine sample لا إذا في fixed persistent proteinuria we need to take a early morning urine sample. How many? We're going to take them on 3 separate occasions. Remember 3 حقنا؟ طيب. We're going to look, when we have this early morning urine sample, we're going to look at the urine protein to urine creatinine ratio. Normally هذا الراتio is less than 0.2 وممكن يصير abnormal. طيب إذا كان normal we will suspect orthostatic وبشرح لكم زيادة عليه. إذا كان abnormal we will suspect tubular or glomerular. طيب what is orthostatic postural proteinuria? First, it is the most common cause of persistent proteinuria in school-aged children. It's defined as an increased protein excretion in the upright position, which returns to normal when the patient is in supine position. يعني وقت النوم patient ما عنده proteinuria. بس سبحان الله لما يقوم ويسوي مهامه اليومية يكمل خلال اليوم يصير عنده. Usually, these children are asymptomatic, and this is discovered on routine urine analysis. يعني مو شرط the patient presents with a specific complaint. طيب how do we diagnose؟ يعني هو ناخذ من العين وهو نايم؟ Well, nope, not quite. The diagnosis is established when the early morning urine sample is taken after being supine over the night. يعني نقول للطفل أول ما تقوم على طول روح الحمام وخذ العينة. لا تدور، لا تروح تسوي حاجة، لا تروح تفطر، لا تقوم تسوي واجبات، على طول أول ما تقوم على الحمام وخذ اليورين sample. If this urine sample is negative, we'll take subsequent urine samples throughout the day, and these will be positive. This will establish the diagnosis of orthostatic proteinuria. The exact cause is unknown, but luckily it's a benign condition, and but long-term follow-up is recommended if there is evidence for kidney disease. متى long-term follow-up؟ نسوي لهم follow-up after 1 year. Okay, so هنا قلنا حقهم early morning urine sample will be normal, no proteinuria. فبعدين we will obtain the other urine samples throughout the day. What about glomerular proteinuria? If you remember nephrotic syndrome is the disruption of the glomerular basement membrane. فيصير عندنا هو فيه negative charge that gets disrupted, which causes the albumin or the proteins that are in the blood to be leaked out through the membrane. So we have an increased permeability of the glomerular capillary wall. The amount of glomerular proteinuria ranges from less than 1 gram, to more than 30 grams per day. So this is a large amount. احنا هنا ايش كنا نقول؟ ماشيين بالمليغرامز. طيب, glomerular proteinuria should be suspected in any patient who has a positive reading based on lab results, or they are symptomatic. يشبه محاولة الدايابيتس يوم تكلمنا عن الموضوع. So if their first morning urine protein to urine creatinine ratio is more than 1, or they have proteinuria of any degree accompanied by hypertension, hematuria, edema, or renal dysfunction. So they are symptomatic. Hypertension, hematuria, edema, and renal dysfunction. Hematuria is seen in presentations that are associated with nephritis. مو شرط يكون موجود. What about tubular proteinuria? هذا a different cause. So هذا قلنا في disruption to the glomerular basement membrane. Here we have a diminished reabsorption capacity of the renal tubules. So tubular proteinuria may be seen in inherited and acquired disorders. The inherited زي مثلا Wilson's disease acquired disorders. أتوقع any renal insufficiency. The underlying disease is usually detected before the proteinuria. Okay. So it's usually secondary to proximal tubular injury, which leads to diminished reabsorption capacity, which will result in low-grade fixed proteinuria. So our urine protein creatinine ratio is less than 1. Here we said it's more than 1. So it can be associated with other proximal tubular dysfunction, زي مثلا Fanconi syndrome. Fanconi syndrome إيش هو؟ It's damage to the proximal tubular dysfunction. It could be inherited or acquired, and it's characterized by impaired reabsorption of essential nutrients and electrolytes. Like what? Like glucose, phosphate, bicarbonate, and amino acids. So we have an impaired reabsorption, meaning they're all going to be excreted. كلهم طالعين مع البول. So we have glucosuria, phosphaturia, bicarbonate wasting, and amino aciduria. So كل شيء قاعد يطلع. هذا هو Fanconi syndrome. Generalized edema is absent. It's because we have a low-grade proteinuria. So there's not enough of drop in the protein levels, the serum, to indicate fluid shift into the interstitium. طيب هذول واضحين؟ So بس هذا هو. We differentiate using the early urine sample, urine protein, urine creatinine ratio. If it's normal, we will suspect orthostatic. If it's abnormal, less than 1, meaning we have a fixed low-grade proteinuria, we suspect tubular cause. And if it's more than 1, we suspect a glomerular cause. And here we have causes of proteinuria in children. هذه مرجع لنا نقدر نمر عليها. So you know which is primary, which is secondary, glomerular, tubular. Okay. Now هذه الأنفية الثانية اللي acquired heavy metal poisoning, acute tubular necrosis, tubular interstitial nephritis, and secondary to obstructive uropathy. طيب. Here is an algorithm for evaluation of asymptomatic proteinuria in children. So this was found on a routine dipstick test. So an abnormal urine dipstick protein in an afebrile child. Why do I not know how to pronounce in an asymptomatic child? طيب لو قلنا في trace التريس إيش كان؟ 15 إلى 30 ملغرام per deciliter. لو قلنا في هذا we have to repeat the dipstick on first morning void in 1 year. خلاص trace we'll just follow up. ما في شيء نسويه. طيب إذا هو plus 1 or more يعني more 30 or more. We have to obtain the first morning void عشان ناخذ protein creatinine ratio وبعد we'll do a urinalysis with microscopic exam. قلنا normal protein creatinine ratio هو 2. لو طلعنا في normal range خلاص we'll follow up in 1 year unless we are suspecting orthostatic. طيب إذا طلع more than 2 or we have an abnormal urinalysis hematuria, pyuria, HMAL protein. ناخذ الهيستوري مفصل, say physical examination, specifically blood pressure. Always routinely take the patient's blood pressure. Laboratory evaluation for creatinine, BUN, electrolytes, cholesterol, albumin, كل الأشياء اللي related to the renal function test. Also, we may consider an renal ultrasound, complement levels, anti-nuclear antibody testing, hepatitis B and C serology, and HIV testing. طيب if the evaluation was normal, we'll repeat the dipstick at least 2 additional samples لأنه قلنا رقم 3 حقنا. And if it's negative, نرجع فوق. We repeat in 1 year. If we have persistent proteinuria, بنرجع لل abnormal evaluation. إذا عندنا abnormal evaluation, just refer to pediatric nephrologist. Okay. نتكلم عن النفروتيك syndrome. هذا نفس الشيء شرحنا electron microscopy layers. والنفروتيك syndrome قلنا عندنا, let's read it actually. Nephrotic syndrome is characterized is basically disruption of the glomerular basement membrane. يكون عندنا increased permeability. طيب معناته هذا glomerular cause of proteinuria. بس اللهم إنه the range of proteinuria is really high. عشان كده نسميه nephrotic syndrome. وعندنا other characteristics. So nephrotic range of proteinuria is greater than 50 milligrams per kg per day. And that's a lot. Or more than 40 milligrams per meter square per hour. Nope. You're okay. So هذا من الكتاب. Urinary protein excretion in the normal child is less than 100 milligrams per meter square per day, or a total of 150 milligrams per day. So do you think there's a child that weighs 3 kilograms? No. So 150 milligrams per day. In neonates, it's higher, which it goes up to 300 milligrams per meter square because they have reduced reabsorption of filtered proteins. طيب. So عندنا إما هذا or هذا, or a first morning urine creatinine ratio of more than 2. So ايوه في الجلوميرولار قلنا بس أهم شيء إنه يكون more than 1. هنا specifically more than 2, يعني هنا كثير. Why would it be more than 2? This is because the protein loss is greater than the liver can compensate. طيب بعد هذا number 1, protein nephrotic range proteinuria. Number 2, we have hypoalbuminemia. So the serum albumin concentration is low. It's less than 2.5 grams per deciliter. We'll have edemia and also hyperlipidemia. The incidence is rare. It's 2 to 3 every 100,000 children per year. طيب, let's go over the pathophysiology of proteinuria, of edema, and hyperlipidemia. So the pathophysiology of proteinuria is the same as what happens in nephrotic syndrome in general. So قلنا عندنا the injury to the glomerular basement membrane leading to an increased capillary wall permeability. It's an immunological process. So عندنا immune complexes or autoimmune process that causes the destruction of the glomerular basement membrane. But the exact mechanism is still unknown. What about edema? We have 3 mechanisms that contribute to edema. أول شيء عندنا hypoalbuminemia. So لأن عندنا hypoalbuminemia in the serum معناته صار عندنا الفلويد أكثر. وين الفلويد أكثر؟ الفلويد أكثر داخل السيرم، وهذا كله طلع. فمعناته إنه الأوزموسيس بيصير لأن الأونكوتيك بريشر decreased داخل decreased داخل في الانترستيشم، فيصير يطلع الفلويد وما عندنا البروتين داخل البلاد فيسلز عشان يرجع الانترstitial fluid، فأنت بس يطلع يطلع يطلع. We also have activation of the renin-angiotensin aldosterone system. فهذا يصير عندنا increased aldosterone secretion, which leads to secretion of ADH, the antidiuretic hormone. فصار عندنا stimulation of distal tubular absorption of sodium، والصوديوم دائما يجي معاه water. فمو بس عندنا الواتر اللي داخل السيروم قاعد يطلع الانترستيشن، حتى اللي المفروض يطلع من الجسم برضه قاعد يقعد داخل. وهذا antidiuretic hormone secretion هنا نفس الشيء. So it's stimulation by reduced intravascular volume, leading to reabsorption of water in the collecting ducts. My bad. هذا aldosterone secretion اللي يخلي الصوديوم يلحق الموية، وبعد هذا السيستم يخلي عندنا ال ADH اللي تجي موية بدون صوديوم. yeah. وآخر شيء pathophysiology of hyperlipidemia. طيب hypoproteinemia stimulates the liver. الليفر الحين بيحاول synthesizes albumin عشان يعوض. طيب الليفر مو بس يعطينا الالبومين، الليفر يعطينا other lipoproteins. وهذه الليبو إيش معنى هذه الليبوبروتينز ما قاعد تطلع بينما الالبومين قاعد يطلع، الكومبلمنت كل شيء قاعد يطلع. هم يخرجون من ليش؟ because they have a high molecular weight, they remain inside the serum. On the other hand, the lipoprotein lipase that is there to destruct this is lost. ما هو زي هذا high molecular weight. فصار عندنا decreased catabolism and an increased synthesis of these lipoproteins. فصار عندنا hyperlipidemia. طيب, classifications of nephrotic syndrome. Any classification, we have primary and secondary. So secondary to any systemic disease. Primary, absence of the systemic disease. عندنا two types. idiopathic nephrotic syndrome، وهذا يشكل 90% من الحالات. وعندنا membranous sclerosis, some cases of membranous sclerosis. Idiopathic nephrotic syndrome also يتقسم إلى minimal change disease, mesangial proliferative disease, and focal segmental granulomatosis. نفصل فيها في السلايدات الجاية. So, okay, primary nephrotic syndrome, absence of systemic disease, includes two subgroups. Well, a subgroup without nephritis, so disorders without glomerular inflammation on renal biopsy. This group includes idiopathic nephrotic sclerosis, idiopathic nephrotic syndrome, and some cases of membranous nephropathy. We have ممكن يكون عندنا glomerular قصدي عندنا nephrotic syndrome with nephritis, meaning we have inflammation, فمعناته عندنا active urine sediment as a result of this inflammation in the form of casts, whether they are red cell casts or cellular casts. So we have inflammation on renal biopsy. This includes membranoproliferative glomerular nephritis and IgA nephropathy. بس يكون عندنا nephritis يكون associated with inflammation، عادة يكون عندنا also hematuria. بس لما نقول إنه في عندنا nephritis في النفروتيك syndrome، فهنا يكون الهيماتيوريا is microscopic، ما هو gross. بمجرد ما نشوف gross هنا نقول إنه it's not nephrotic syndrome. Secondary nephrotic syndrome معناته عندنا systemic disease. طيب إيش الساينز أو الريد فلاجز اللي تخلينا نقول إنه في systemic disease؟ أول شيء age older than 8, hematuria, mainly gross hematuria, because the hematuria, the microscopic hematuria, renal dysfunction, low complement levels. This is because كان في systemic inflammation وأشياء cause the depletion of the complement, of the complement. Or extrarenal manifestations زي مثلا في الفاسكولايتس في الSLE. So عندنا rash, arthalgia. What are the potential causes؟ فكروا بأي مرض autoimmune وسيستميك عرفنا عنه قبل. So SLE, vasculitis, Henoch-Schlein purpura, wet Wegener, anything. Chronic infections such as hepatitis B, hepatitis C, malaria, HIV, any allergic reactions, diabetes, amyloidosis. diabetes amyloidosis ليش ممكن يسمى nephrotic syndrome؟ لأن احنا قلنا nephrotic syndrome عنده disruption of the glomerular basement membrane. هذولي عندهم عندهم سواء الاميلويد أو الجلوكوز. They can deposit into this glomerular basement membrane, disrupting its function, increasing permeability, causing nephrotic syndrome. نفس الشيء مع malignancies. We have congestive heart failure, restrictive pericarditis, and renal vein thrombosis. Our treatment here is treating the underlying cause. ما يحتاج نسوي أي شيء specifically للكدني. طيب, let's talk about the first type of primary nephrotic syndrome, specifically the ones without nephritis. Idiopathic nephrotic syndrome. So idiopathic nephrotic syndrome is the most common form of childhood nephrotic syndrome. Basically, أول ما تشوفون a child and the nephrotic syndrome, first thing you think of is probably idiopathic nephrotic syndrome, and 90% of the cases between 1 to 10 years of age, or 50% after 10 years of age. It's still the most common after 10 years, but after 10 ممكن we suspect any other causes. سواء هي من red flags قلنا هنا older than 8 أو الأنواع الثانية ذكرناها للnephrotic syndrome, primary nephrotic syndrome. Okay, so we have 3 types of idiopathic nephrotic syndrome زي ما ذكرنا. Based on histological classification, we have minimal change disease, mesangial proliferative nephrotic sclerosis, and focal segmental glomerular sclerosis. Minimal change disease is the most benign out of these, or the most common. Focal segmental glomerular sclerosis, it has a poor prognosis, and mesangial proliferative is considered to be a transitional phase between the 2 subtypes. طيب, first, let's see minimal change disease. It accounts for about 85% of total cases of nephrotic syndrome in children. In all of these بتلاحظون إن الريشيو male to female أكثر, المale 2 to 1. كل kidney diseases الحين. ومثل نقول طب females more لما يكون في an autoimmune cause. The common age of presentation is 2 to 6. طيب, هو إيش كيف يجي minimal change disease؟ يعني هو it's a chronic disease. يقول الدكتور إنه يحب يقول الأهالي إنه يشبه حساسية الصدر أو الربو. فيكون عندنا initial episode, a triggering episode, مع subsequent relapses, which may need acute treatment. So some cases may require maintenance therapy, and some cases only need acute treatment. What triggers it? زي حساسية الصدر عندنا triggers, so minor infections, reaction to insect bites, bee stings, poison ivy. هو ما يجي لأي طفل, بس يجي للأطفال اللي عندهم predisposition to develop minimal change disease. فمو أي طفل مثلا يتعرض هذه الأشياء يعني خلاص نمنعه, يعني أول ما يجي any insect bite نخاف عليه من مشاكل في الكلى. لا. معلومة إضافية قالها الدكتور, 80% of children may outgrow minimal change disease and actually asthma. So that's just a fact. Wait, hold on. Okay. And more than 90% of children with minimal change disease respond to corticosteroid therapy. So this is really good. نفصل في corticosteroid therapy in its own slide later. The second type, mesangial proliferative type. 50% of patients here respond to corticosteroid therapy. So هنا شوي أقل. And lastly, we have focal segmental glomerular sclerosis. When we say focal, so we mean that only some glomeruli glomeruli are affected. مو كلها اللي موجودة في الكلية. So بعض الجلوميريولاي متأثرة. ولما نقول segmental جزء أو segment من هذه الجلوميريولاي also I hate this word also affected. So زي هنا segment. هنا you can clearly see the affected sclerosed part. تشوفون الهايلاين forming. Okay, unlike microscopy here, glomeruli show lesions that are focal, present only in a proportion of glomeruli, and segmental, involving part of the glomeruli. The lesions consist of mesangial cell proliferation and segmental scarring. So هذه هي segmental scarring. والmesangial proliferation لو تتذكرون هنا المفروض يكون فاضي عندنا في وسط الجلوميرولس نفسه، بس هنا في cells صار مليان. Only 20% of patients with focal segmental respond to corticosteroids. فكل شوي يقل. وهذا has the worst prognosis because the disease is often progressive, leading to end-stage renal disease. خلصنا الحين من types of the primary nephrotic syndrome، أو بالأصح types of the idiopathic primary nephrotic syndrome. Now, what are the clinical manifestations and complications of nephrotic syndrome? We know them زي ما شرحناهم قبل. Generalized edema. So أول ما تشوفون periorbital edema, you need to suspect proteinuria among your differential diagnosis. So بتكون مثلا hypothyroidism, ما أدري allergy. Also فكروا هذا لأنه very dangerous. So because initially it starts around the eyes and in the lower extremities. So it's pitting edema من المشى كذا يفيد indent. Then it becomes generalized with weight gain, ascites, pleural and pericardial effusion, and scrotal and abdominal wall edema. The edema accumulates in dependent sites and shifts from the face and back to the abdomen and legs as the day progresses. And abdominal pain, anorexia, diarrhea, hyperirritability are also common. إنه في disruption of the fluids عندنا، فممكن يصير يملأ حول السtomach causing anorexia. ممكن يصير حول البowel causing diarrhea. ما في وقت للكايم نفسه يقعد في الintestines والhyperirritability. Blood pressure. So usually blood pressure is normal because it's normal to reduce due to hypovolemia in most cases. Hypertension, though, is present in about 5 to 10 of patients, but when we see it, it's suggestive of a more of focal segmental glomerular sclerosis, يعني a more severe cause of nephrotic syndrome, or ممكن we suspect other causes تكون associated with nephritis. عندنا increased tendency to arterial and venous thrombosis and embolism. These tendency هذا نلاحظه مع episodes of relapse. So nephrotic syndrome is a hypercoagulable state resulting from multiple factors. Why is it hypercoagulable? عندنا vascular stasis لأنه في compression from the outside بسبب الفلويد اللي في الانترستيشم يضغط على blood vessels، صار عندنا stasis. عندنا increased in hepatic production of prothrombotic factors. ليش هذا؟ زي ما قلنا إنه صار في عشان تعويض الألبومين صار في increase of lipoprotein. بعد عندنا increase of the coagulation factors. عندنا decreased serum levels of anticoagulation factors لأنهم they're being lost. So they're being lost, but then they're being rapidly نعوضهم. و increased plasma platelet production as an acute phase reactant. هذا في الحالات اللي يكون فيها inflammation ويصير عندنا increased platelet aggregation. طيب إيش اللي ممكن يصير لما نقول إحنا عندنا venous thrombotic events؟ ممكن يصير عندنا renal vein thrombosis, pulmonary embolism, sagittal sinus thrombosis in the brain. Prophylactic anticoagulant therapy is not recommended unless the patient has had a previous thromboembolic event. So we need to أول شيء نثبت إنه قد صار له قبل عشان نقدر نعطيه. مو أي أحد عنده nephrotic syndrome نخاف عليه من thromboembolic events. وآخر شيء increased susceptibility to bacterial infection. لو تذكرون يوم تكلمنا إحنا في سنة رابعة عن الليفر cirrhosis، تكلمنا إنه في spontaneous peritoneal infection. فهذا why is that؟ نشرح شوي زي الحين. Because edema acts as a culture medium perfect for bacteria، ولأنه عندنا decreased in proteins overall including immunoglobulins which defend against infections تبع البي cells، وبعد عندنا loss of a complement that opsonizes bacteria. So عندنا immune system proteins حق immune system كلها قاعد تنزل. نفس الشيء leukocytes عندنا defective cell mediated immunity because immunoglobulins كلها طلعت. The use of immune suppressive medications to treat nephrotic syndrome اللي هو الcorticosteroids، كل هذه الأشياء تجمعت على بعض. آخر شيء decreased perfusion to the spleen due to hypovolemia. كل الأشياء تجمعت على بعض سوت لنا increased susceptibility to bacterial infection ويصير البيشنت عندنا يعتبر immunocompromised. So patients with nephrotic syndrome are considered immunocompromised. إيش الأسباب؟ الإديمة نفسها culture medium، عندنا decreased of immune proteins which causes disrupted cell-mediated immunity، وعندنا use of corticosteroids، وعندنا آخر شيء hypovolemia which caused decreased perfusion to the spleen. Okay, spontaneous bacterial peritonitis is the most frequent type of infection. The infection may also be present as cellulitis, pneumonia, septicemia, or UTI. So in a patient with nephrotic syndrome, don't only look for spontaneous bacterial peritonitis عشان يعني infection في الإديمة نفسها، لا. Increased susceptibility to all infections anywhere. So just ask about infections in general. The commonest organism is strep pneumonia. وalso عندنا Haemophilus influenza and other gram-negative bacteria. Strep pneumonia. And lastly, complications of hyperlipidemia are rare in pediatrics. However, they may occur as these patients get older. So what are the laboratory investigations we want to do? So we're going to look at urine, we're going to look at blood, and I think physically, yes. We're going to look at blood, we're going to look at urine, and we're going to do a renal biopsy if indicated. So in blood, بيكون nephrotic syndrome, we're losing protein, so we have decreased albumin. عندنا hyperlipidemia, so serum cholesterol would be high. Serum complement level, C3, will be normal. We say C3 specifically because in hematuria, we'll see that it will be low. The complement level is normal here. If it's changed, suspect nephritis or hematuria. BUN and serum creatinine, they are usually normal or mildly elevated in case of intravascular depletion. They may be mildly elevated if as an acute phase reaction. So هنا أهم شيء عندنا نعرف serum albumin, serum cholesterol. urine. So you may have oliguria. This is because the body is trying to not lose more protein. قاعد يحاول يقلل إخراج البول، فعندنا oliguria. Increased concentration of urine, so increased specific gravity. Proteinuria, more than 40 milligrams per meter square per hour. Or on the urine dipstick or spot urine to creatinine ratio is more than 2. more than 2 للnephrotic syndrome. تذكرون يوم قلنا glomerular causes of proteinuria كم يكون؟ أكثر من 1. والtubular أقل من 1. nephrotic syndrome أكثر من 2. الطبيعي 0.2 أو أقل. And if we have hematuria, then it is microscopic, and it may be present in around 20% of patients. لو شفتوا gross hematuria فهذا ما يعتبر minimal change disease anymore، ونفكر بأسباب ثانية وغالبا يكون فيها nephritis. The renal biopsy is not routinely performed in children. متى نسويها؟ if we suspect nephritis، فإذا عندنا gross hematuria، إذا عندنا hypertension، تذكرون؟ الاثنين. if we have renal insufficiency، لا هنا في حاجة يعني صرنا stage خطير شوية. hypocomplementemia. This is because نفس الشيء موجود في النفرايتس وبينذكر تحت زيادة. If the age is less than 1 or more than 10, because minimal change disease is usually from 1 to 10. لو كان أكثر ممكن يصير another cause. مو شرط، لسه minimal change disease is the most common، بس معناته we have to suspect something else. And after initial steroid treatment in case of steroid resistant nephrotic syndrome. نتكلم إيش معنات steroid resistant over here. And before starting a second line medication in case of steroid dependent or frequent relapsing nephrotic sclerosis. So إذا عندنا نفكر nephritis، إذا العمر less than 1 more than 10، إذا الكيس is steroid resistant، وإذا نبغى نغير الميديكيشن لأنه عنده frequent relapsing أو صار steroid dependent. التريتمنت، طبعا التريتمنت احنا ما ننط على طول على الفارماكولوجيكال، عندنا lifestyle modifications وبعدين الفارما. So first we're going to observe مع الfollow-ups. We're going to look at their temperature for possible infection. We're going to measure their daily weight because any weight gain is equal to fluid retention in these cases. Blood pressure، لأنه إذا زاد blood pressure we suspect إنه ممكن يكون focal segmental أو a cause أو nephritis rather than minimal change. وطبعا urine volume, because urine volume is the first indication of adequate response to treatment. لازم يكون increased urine output. ونشوف specific gravity، نشوف إذا هو no longer concentrated، والprotein excretion daily. هذه daily observation. Diet، الدكتور قال أهم حاجة 2 words، well 2 things: salt restriction and low fat diet. So due to the tendency to retain sodium, salt restriction is terminated when edema resolves. Okay, fluids, usually not restricted except in case of hyponatremia or when there is weight gain despite sodium restriction. Protein, high intake; fat, decrease intake. لأن عندنا الهايبرلipidemia أصلا. So drugs. We can diuretics like loop diuretics, furosemide or thiazide. Could be thiazide. So كان كتبت صليب. They're not routinely used in pediatrics, especially when there is intravascular volume depletion. They can be used in case of moderate to severe edema. سواء ما نستخدمهم عادة. ممكن نستخدم furosemide or hydrochlorothiazide combined with spironolactone. This is only if قلنا severe. والsevere إيش معناته؟ if the edema is symptomatic، معناته عندنا صار في ال other body systems، صار عندنا pleural effusion، صار عندنا general edema. هنا ممكن نستخدم diuretics. طب متى نعطي المريض albumin straight up؟ الalbumin هذا نسميه salt poor human albumin. We give it in cases of marked hypoalbuminemia with severe edema, severe symptomatic, especially pleural effusion or genital edema. Okay. Lastly, finally, corticosteroid therapy. Okay, so a corticosteroid is an immunosuppressant. OSHA-TB should be ruled out before starting any steroids. ليش معنى TB بالضبط؟ لأن TB has a latent form، وإحنا ما نبغى we suppress the immunity عشان latent TB هذا يجي يعني قلنا surprise. But this step of ruling out TB may be skipped in non-endemic areas. أصلا هو الطريقة اللي بنسويها بيكون by ال skin test. طيب the steroid treatment protocol. Okay, wait, hold on. Okay, steroid treatment protocol, 60 milligrams per meter square per day. So 60 milligrams. أو يكون عندنا 20 milligrams per kg. So 60 هين. Is given as a single dose or divided into 2 doses daily for 4 to 6 weeks. The maximum daily dose حقنا هو 60 to 80 milligrams per day. بعدها نقلل الدوس. أول شي بدنا 60 نقلله ل40 ونعطي every other day. أول شي قلنا 60 daily for 4 to 6 weeks، بعدين 40 every other day كل يومين for 4 to 6 weeks. 4 6. Then we start to taper the dose gradually every other day over 2 to 3 months. Okay. طيب. Response to steroids. When do we say we have remission? هنا ترجع 3 حقنا. So if we have a negative urine protein for 3 consecutive days هذا عندنا remission. ومتى نقول relapse؟ إذا صار عندنا protein plus 2 or more for more than 3 days with hypoalbuminemia and edema. So it's symptomatic proteinuria. أما steroid resistant، وقلنا steroid resistant هو اللي في حالته بناخذ لنا renal biopsy. They are patients who fail to have remission after 4 to 6 weeks of steroid therapy. So they fail to have remission after, it goes 4 to 6, after 6 to 8 weeks of steroid therapy. First, they'll need a renal biopsy. We immediately perform. Then we'll give them a different immunosuppressant. So second line treatment is cyclosporine and tacrolimus, which are also potent immunosuppressants. So ما ضبط معاهم الcorticosteroid نعطيهم a different immunosuppressant, cyclosporine, tacrolimus. Patients with steroid resistance usually have an other pathology rather than minimal change disease. نحن نقول minimal change disease 90% respond. They may have focal segmental, myeloproliferative glomerulonephritis, membranous glomerulopathy, mesangial proliferation, whatever it is. And these children with steroid resistant glomerulonephritis or nephrotic syndrome have poor outcome with a high percentage reaching end-stage renal disease requiring dialysis and a renal transplant. Okay. خلينا نشوف أسئلة عن الموضوع. Okay, so we have here 12-year-old boy was discovered during a routine medical checkup before joining the football team to have +2 proteinuria. Wait. He's not known to have any illness before. His examination and laboratory investigations otherwise are normal. A test was done 1 week later with the same result. His doctor told him to do the test immediately after getting up from bed in the morning, and the test was negative for protein. What would be your diagnosis? 3, 2, 1. It is orthostatic proteinuria. Okay, our next question. Steroid resistance is defined as failure to have remission after how many weeks? 3, 2, 1, 6 to 8 weeks of steroid therapy. Okay. A 4-year-old male presented with edema on examination. He had normal blood pressure, generalized edema, proteinuria +4, and a normal renal function test. What would be your diagnosis? Okay, 3, 2, 1. It is minimal change disease. First, go to normal blood pressure, so we exclude nephritis. Generalized edema, proteinuria, هنا نقول nephrotic syndrome. عندنا يا إما minimal change يا إما focal segmental. Focal segmental قلنا إنه بعد يكون عندهم elevated blood pressure. وإذا بنمشي على the most common in general بنقول هو minimal change disease. Okay, باقي 3. A patient has proteinuria, hematuria, hypocomplementemia. What is your next step? قلنا الهايبوكومبلمنت والهيماتيريا نسوي لهم مو الهيماتيريا يعني الهيماتيريا لازم يكون جراس، بس الهايبوكومبلمنتيميا نسوي لهم على طول biopsy لأنه we're suspecting nephritis. Which of the following is not a characteristic of minimal change nephrotic syndrome? 3, 2, 1. hypervolemia لأنه عندنا hypovolemia داخل السيرم لأن كل الفلويد راح للinterstitium. Last one. What test gives you the precise info regarding protein in urine? 3, 2, 1. 24-hour collection. قلنا urine dipstick is part of a urine analysis, and a urine analysis includes visualization و description. الurine dipstick هو التست نفسه حق الستيك. قلنا عنده مشكلة واحدة إنه it is less sensitive to identifying the type of protein other than albumin. renal function test ما يعلمنا عن اليورين نفسه، قلنا عن renal function. microalbuminuria, is that even a test? Be for real. And so the answer is E.